Welcome to This Week in Orthopedics. This week we're covering 10 notable papers spanning shoulder and elbow surgery, bone health and spinal deformity, and the durability of joint preservation and biologic treatments. Let's dive in. We'll start with the shoulder, where 3 papers approached the same joint from very different angles. In the Journal of Shoulder and Elbow Surgery, Harkin and colleagues tackled one of the most contentious decisions in shoulder arthroplasty: what to do with the biconcave or severely retroverted glenoid in a patient who still has an intact rotator cuff. They compared anatomic total shoulder arthroplasty using an all-polyethylene posterior augmented glenoid against reverse total shoulder arthroplasty in Walsh B2 and B3 glenoids, drawing on prospectively collected data from just over 200 shoulders, and then propensity matching 36 patients per group on age, sex, and retroversion. At 2 years, the patient-reported outcomes were essentially superimposable: American shoulder and elbow surgeon scores of about 88 in both arms, identical pain scores, and the same rates of achieving minimal, clinically important difference. Revision rates were low in both groups, around 3%. Where the groups diverged was motion and radiographs. The anatomic group gained roughly 8 more degrees of external rotation and about 13 more degrees of forward flexion, but radiolucency around the glenoid component was seen in about 4 in 10 anatomic shoulders, compared with fewer than 1 in 10 reverse shoulders. That's a level 3 retrospective comparison with small matched groups, and 2 years is early for a polyethylene glenoid. The practical reading is that both operations work. The anatomic augmented glenoid buys motion in a younger patient with an intact cuff, and the radiolucency signal is a reason to keep these patients on the radar rather than a reason to abandon the implant. Staying in the shoulder but moving to instability, the American Journal of Sports Medicine published 5-year follow-up on arthroscopic ladder jet from Berge and colleagues in Oslo. 85 patients, mostly young men, and a genuinely hard population. 2/3 of the cohort had more than 10 dislocations before surgery, and over 4 in 10 were revision procedures. At a median of just over 5 years, only 2 patients had recurrent dislocation and 8 reported subluxations. Western Ontario Shoulder Instability Index scores improved substantially and, importantly, were stable between 1 year and 5 years, so the early result is the durable result. Quality of life on the EQ-5D matched general population norms, and 87% of patients were satisfied. 10 patients did require reoperation for complications, which is the number to quote in consent. Set against that, JAMA Internal Medicine published a review by Haas and colleagues on shoulder pain in primary care that pushes hard in the opposite direction for the far commoner non-traumatic presentation. They argue for the umbrella term subacromial pain over the tangle of impingement, bursitis and tendinopathy labels, and they make the case that early imaging is not indicated without trauma or red flags, because structural findings often don't correlate with symptoms and generate overtreatment. Their strongest statement is that high-certainty evidence shows subacromial pain does not benefit from surgical intervention. Read together, these 2 papers draw a clear line. Structural instability with bone loss is a surgical problem with excellent durable results, while atraumatic subacromial pain is a watchful waiting problem, and the harm comes from confusing the two. Rounding out the upper limb, a systematic review in the Journal of Shoulder and Elbow Surgery from Nadim and colleagues pooled 10 comparative studies and more than 1,700 patients undergoing distal biceps tendon repair with either cortical button or suture anchor fixation. Function, range of motion, and strength recovery. Around 85 to 95% of the contralateral limb were comparable, and pooled complication rates showed no significant difference in re-rupture, lateral antebrachial cutaneous nerve neuropraxia, or posterior interosseous nerve palsy. The striking number is that nerve events dominated the complication profile, with lateral antebrachial cutaneous neuropraxia accounting for about 2/3 of all complications and occurring in roughly a quarter of patients in both groups. So the implant debate looks settled by equipoise, and the consent conversation should center on sensory nerve symptoms rather than on which device you plan to use. The second theme this week is bone quality as a modifiable target in spine surgery, and here 2 papers in spine sit in productive tension. Mayan and colleagues performed a systematic review and meta-analysis of perioperative anabolic osteoporosis pharmacotherapy in adult spinal deformity surgery, 13 studies, over 2,000 patients, with teriparatide the agent in 9 of them. Anabolic therapy around the time of surgery was associated with roughly half the odds of proximal junctional kyphosis and about a third of the odds of reoperation for mechanical failure. Heterogeneity for the kyphosis outcome was 0, and leave one out analysis preserved the direction of effect. The honest caveat, which the authors state plainly, is that only 1 of 13 studies was randomized, and the certainty of evidence is low. Alongside it, Lim and Kang published a synthesis without meta-analysis review, focused specifically on degenerative lumbar scoliosis and long segment fusion. They found that most core reports linked lower bone quality to mechanical complications, with osteoporosis associated with several-fold higher odds of screw loosening and of mechanical complications, but they declined to pool anything, citing retrospective design, probable cohort overlap, inconsistent regression tables, and measure-dependent null findings, and they graded certainty as very low. Their verdict on perioperative anabolic therapy is that it is promising, but not definitive, and that no class effect specific to degenerative lumbar scoliosis has been established. The clinical signal is consistent even where the statistical confidence is not. Screen bone density before long fusions and treat osteoporosis as something you act on preoperatively rather than merely document. The modifiable risk theme continues in the third spine paper, an observational study from the Canadian Spine Outcomes and Research Network, reported by Chan and colleagues, covering more than 6,000 patients undergoing surgery for degenerative lumbar conditions. 37% had obesity, and about 5% had a body mass index of 40 or above. Patients with any class of obesity were less likely to reach the minimal clinically important difference on the Oswestry Disability Index at 1 year, with the effect most pronounced in severe obesity. The complication gradient was steeper. In Class 3 obesity, incidental durotomy was modestly more common, surgical site infection about half again as likely, and wound dehiscence more than doubled. These patients still improve. They simply improve less reliably and with more perioperative trouble, which is a shared decision-making conversation, not an automatic exclusion. Finally, 2 papers on durability and biologics. In knee surgery, sports traumatology, arthroscopy, Gosnell and colleagues reported minimum 10-year outcomes after primary hip arthroscopy for structurally stable femoral acetabular impingement performed with interportal capsulotomy and no capsular repair. In 150 patients followed a mean of nearly 12 years, survivorship was about 91%, with roughly 5% converting to hip arthroplasty and another 5% undergoing revision arthroscopy. Modified Harris hip score improved by around 36 points, and about 3/4 of patients reached an acceptable symptom state. Female sex and higher body mass index predicted worse 10-year scores, while tonus grade 1 changes and lower preoperative function predicted outright failure. This is a single surgeon level IV series without a comparison group, so it doesn't resolve the capsular repair debate. But it does give you decade-long benchmarking numbers for counseling a well-selected, structurally stable hip. In the same journal, Delgado and colleagues published a meta-analysis with meta-regression of placebo-controlled trials of platelet-rich plasma in knee osteoarthritis. Across 20 studies and roughly 3,300 patients, platelet-rich plasma beat placebo for pain and function at both 6 and 12 months. But the certainty of that evidence was rated very low. Younger age, a higher platelet increase factor, leukocyte-rich preparations, and calcium chloride activation were all associated with better 6-month function. Yet these variables were interrelated. None of them explained results at 12 months, and the authors are explicit that this is hypothesis-generating, not a mandate for a particular formulation. One more paper deserves attention for what it dismantles. In the Journal of Bone and Joint Surgery, Berthelsen and colleagues tested the assumption that antibiotic-loaded ceramic bone grafts deliver 4 to 6 weeks of local protection. Using a murine implantation model with mass spectrometry quantification, they found that both commercial gentamicin-loaded products, the hydroxyapatite calcium sulfate composite and the pure calcium sulfate, released more than 98% of their antibiotic within 6 hours and more than 99% within 24 hours in vivo. Their reanalysis suggests the apparent prolonged elution in earlier laboratory studies was an artifact of serial dilution in the assay, rather than sustained release. If you are relying on these grafts for weeks of local antimicrobial cover and bone infection, that assumption is not supported. If you only have time for one paper this week, make it the Journal of Bone and Joint Surgery study on antibiotic-loaded ceramic bone grafts. It directly contradicts a widely held belief that shapes how many surgeons plan systemic antibiotic duration and dead space management in bone infection, and the practice implication is immediate. Here are the key takeaways from this week in orthopedics. Antibiotic-loaded ceramic grafts give a burst, not a depot. Don't shorten systemic therapy on the assumption of weeks of local cover. In Walsh B2 and B3 glenoids with an intact cuff, anatomic arthroplasty with a posterior augmented glenoid and reverse arthroplasty give equivalent 2-year patient-reported outcomes. Anatomic gives more motion, reverse gives cleaner radiographs. Arthroscopic letarget holds up at 5 years in a hard instability population, while atraumatic subacromial pain should be managed without imaging and without surgery. Bone health is emerging as a modifiable target before long spinal fusions, with anabolic therapy associated with fewer proximal junctional kyphosis events, though the evidence remains low certainty. And in both lumbar fusion and hip arthroscopy, elevated body mass index consistently predicts less improvement, worth quantifying in the preoperative conversation. That's your roundup for this week in orthopedics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.